One.
So good morning. I'm going to talk on positioning of dapagliflozin as an integral part for the management of heart failure. And to begin with, let me discuss few case studies first. This is a 70-year-old male who is having hypertension, obesity, and diabetes since 18 years. Though he did not had any prior history of heart failure, but now this time presented with typical symptoms of heart failure like dyspnea on rest with pedal edema and RELS and elevated JVP. On investigation, he has an ejection fraction of 30% with elevated NT-proBNP level. He also has a CKD with the eGFR 50 and increased urinary albumin creatinine ratio to 150. His diabetes is otherwise well controlled on insulin glargine, metformin, and sitagliptin. He is also receiving ACE inhibitor and beta blockers for hypertension. Now, this is a patient with type 2 diabetes, CKD, and heart failure. What should be our next line of management? Another case, a known case of HFrEF, 60 years age, CAD, hypertension, and he is non-diabetic. He was diagnosed to have HFrEF 2 years ago. And now he again comes with a worsening of symptoms of dyspnea on exertion while pedal edema. And historically, he had frequent hospitalization more than 5 times in last 2 years. Very high NT-proBNP level with ejection fraction of 25%. GFR 60 with increased UACR. He is on calcium channel blocker, beta blockers, ACE inhibitors were added 2 years ago because of HFrEF. Currently, though on a suboptimal dose with MRA, which were discontinued because of hyperkalemia issue, and he's on a standard care for acute coronary syndrome. So now this patient, what should we do for his heart failure management? And another case where HFrEF is there with a worsening of renal function. This is a 65-year male diagnosed with heart failure 3 years. And he has frequent heart failure hospitalization. He had CAD hypertension, but he's a non-diabetic. Now somebody with a CAD, hypertension, frequent heart failure, and already receiving so many medications, and here again, his mineralocorticoid receptor antagonists were discontinued because of hyperkalemia. And he comes again with deterioration of the symptoms of heart failure like dyspnea and pedal edema. Also has a high NT-proBNP level with an echo showing 35% of ejection fraction. And in a setting of a GFR of 38, obviously this cardio-renal connection is very strong in this patient. And his NT-proBNP level is increasing and his GFR has gone down in last 4 months. That means here the heart failure is worsening and CKD is also worsening. So what should be the next line of management for such a patient? So we know that these are the standard of care guidelines which were around 4 or 5 years ago, like patients with symptomatic HFrEF treat with beta blocker and then add on mineralocorticoid receptor antagonist, and if they are able to tolerate ACE inhibitor or ARB, consider those. If there is a no bradycardia, then consider evaporating, or if there is a sinus rhythm, etc., abnormality are going on with a prolonged QRS, then consider CRT, etc., etc. But nowadays things are changing, and that is what is the objective of discussion. And then came the ARNI era, where we saw the paradigm heart failure trial, which has shown that there was a 20% benefit with ARNI when it was compared to ACE inhibitor. And that's how the era for ARNI started. But we simultaneously can see that still, in spite of addition of ARNI, there is a big residual risk for heart failure remains. So what can we do additional? And here, the thing which has happened, that is after the era of SGLT2 inhibitors, we saw a big change in the management of not only diabetes, but other cardiac and renal disorders. And there we have Now, new trial data for dapagliflozin on heart failure, particularly in with reduced ejection fraction. So let me talk on the DAPA heart failure study, where the dapagliflozin was used in patients of heart failure irrespective of their diabetes status. And this trial was done to test the hypothesis that SGLT2 inhibitors, they were found beneficial in heart failure with diabetes, but this benefit is not due to just glucose reduction. That means these drugs should be effective in heart failure without diabetes as well. And that's how this big trial of 4,744 patients was initiated. And only patients with known heart failure were included in this study with elevated NT-proBNP level with LV ejection fraction of less than 40% within last 12 months. eGFR was more than 30. The standard care was continued. And now we can see here that the dapagliflozin was given in the half of this population while remaining half received placebo. And the objective of the trial was to find out the composite endpoint of cardiovascular death, hospitalization due to heart failure, and worsening of heart failure requiring urgent visit with these remaining secondary endpoints. In this population, this is a very interesting data of this DAPA heart failure trial where the mean age of the patients was 66 years. The BMI average was 28 and a heterogeneous population with 23.5% were Asian with a GFR mean was 66. Though we had many patients with a eGFR around more than 30, so around 40, 45 like that. And interestingly, the mean NT-proBNP level median was more than 1400 with a mean ejection fraction 31%. And in this trial, we can see that around 11% patients were on ARNI, that is sacubitril valsartan drug as well. And now if we look at the results, and these are the various anti-diabetic management going on. So this is a trial where 45% patients were having heart failure with type 2 diabetes, while 55% participants had no type 2 diabetes, but they had heart failure. And I had already discussed the inclusion criteria, ejection fraction less than 40% with a high pro-BNP level. And now what we saw, there was a significant reduction in composite endpoint, that is cardiovascular death or worsening of heart failure by 26%. Cardiovascular death was reduced by 18%, and hospitalization due to heart failure was reduced by 30%. So all values very significant. And the consistent benefit was seen across for hospitalization due to heart failure, all-cause mortality. There was a significant improvement in heart failure symptoms. So overall, this was a well-tolerated drug, proven to be very useful in patients who are having heart failure, irrespective of diabetes status. That is what we learned. And significantly reduced risk of CV death started from day 28. So when we start this therapy, around 1 month, we are going to see, from 1 month onwards, we are going to see a benefit. And here we can see that the benefit was irrespective of the glucose status, both normoglycemic, pre-diabetic, and type 2 diabetic. All the population had more or less same benefit. So dapagliflozin, in addition, reduced the incidence of new onset type 2 diabetes in that cohort which was having pre-diabetes, and this was expected. This was irrespective of eGFR status. We can see that the dapagliflozin had a benefit in patients with heart failure. That means in a combination of heart failure, if the eGFR is in addition low, then this becomes a very good indication for a SGLT2 inhibitor like dapagliflozin. And we can see across all age, across all groups, we can see a good benefit of dapagliflozin in comparison to placebo. Here we can see the difference in the all groups. And this is the most interesting one important area in this trial. Around 10% patients were on ARNI as well. And we can see here that 41 patients in the ARNI plus dapagliflozin had event, while 56% patients in ARNI without dapagliflozin. That means if dapagliflozin is added on the top of ARNI, the benefit are same with a hazard ratio of 0.75. That means this combination also can have an additional advantage. And these are the safety profile. Overall, dapagliflozin was reasonably safe. No big volume depletion kind of issues or renal adverse event, which were thought of very in the beginning when SGLT2 inhibitors were launched. And we can see here everything was reasonably good. So in general, dapagliflozin versus placebo, we did not saw any significant adverse effect profile. The urinary tract infection rate was slightly higher in the dapagliflozin group as compared to placebo. That is expected. These genital mycotic infections were relatively higher. This is another study on HFrEF, which is EMPA-REG, that is the EMPERA reduced versus dapagliflozin. And here we can see that there are differences among these two studies, and in fewer areas, dapagliflozin had shown a better response in DAPA-HF as compared to EMPERA reduced study. So what should be the positioning of dapagliflozin now as far as the heart failure is concerned? And we can see this is the 2020 heart failure ESC position paper, which suggests that dapagliflozin could be considered in the treatment of patients with HFrEF with and without type 2 diabetes. We know that the US FDA has already approved dapagliflozin for the treatment of heart failure irrespective of the diabetes status, and that is specifically for HFrEF. This is the Canadian Cardiovascular Society Guideline Update 2020, which again says for a recommendation of SGLT2 inhibitor such as dapagliflozin, because we have seen the data of DAPA heart failure study. So dapagliflozin, like SGLT2 inhibitor, should be considered in patients with ejection fraction less than 40%, because this has shown benefit in terms of survival, reduced mortality, as well as reduced worsening or hospitalization of the heart failure. And that's how things are now changing from 2016, and we are seeing that there is a modification in the guideline. And now patients who are symptomatic with heart failure due to reduced ejection fraction, apart from ACE inhibitor, beta blocker, mineralocorticoid receptor agonists like conventional therapies, now SGLT2 inhibitors are coming right from beginning, and that's what are the recommendations. So SGLT2 inhibitor can be added at any stage, and this is a new learning, and that's how we can see that the big advantage of SGLT2 inhibitor as compared to other therapy for the heart failure is single dose. Just a morning single dose. No dose titration needed. And many benefits, which is a very big topic. And that's how it's a very easy therapy to initiate for any patient. And that's how patient selection, then the dose selection, pre-initiation consideration, prescription, long-term, everywhere, dapagliflozin is too easy to manage. Just start with 10 milligram in all patients, provided the GFR is more than 30. In patients with HFrEF, irrespective of diabetes status, and some adjustment in the concomitant medications, particularly loop diuretics and the antihyperglycemic drugs can be done. And that's how the DAPA heart failure trial has now added one more pillar in the management of heart failure with reduced ejection fraction. And that's what we can see. And that's how now we can do the management of heart failure of our diabetic as well as non-diabetic patients in a better way. Thank you very much.